All right, so I apologize for that little glitch. Are you able to hear me now? If anyone could type in. Okay, excellent. Perfect. So let me start over. Very special welcome to everybody who is tuning in for our EBFA webinar. If this is your first time tuning in, very special welcome. If you are one of our EBFA followers and part of our family, then very special welcome to you as well. So this is a very exciting topic. This is something that I'm very passionate now. I'm on this continuous journey of exploration of how we can help our clients and patients and athletes even more. And I hope that this webinar is going to give you some of that information on how you could look at some of this movement dysfunction and chronic pain in a slightly different perspective. As always, this webinar, like all of our webinars, will be recorded. If you want to re-listen to this webinar, it will be found on our YouTube channel, which is youtube.com/EBFA Fitness. Again, youtube.com/EBFA Fitness. You will be able to find this webinar as well as over 100 videos that are all intended to enhance your education. If you would like the PDF of this PowerPoint, please email me at education@ebfafitness.com. If you have any questions, we will be going through those at the end. So I'm going to run through the presentation and then save those questions. If you want to type them in as you're coming up with those questions, you may do so in the control panel where there is questions. Just making sure that all is okay. Okay, everyone is amazing and can hear. Great. So we are jumping on into it. So there were some of you who are online that I see that were at our Barefoot Summit. And at the Barefoot Summit, I did do a presentation on this topic. But since then, I have added additional information. So if you did hear this at the summit, if you did hear it when I was on a Facebook Live, just know there is some additional information in this. So we are jumping on into this. If you are new to EBFA and you're not quite familiar with who I am, my name is Dr. Emily. I am a podiatrist, human movement specialist. I practice in Manhattan. I also do consulting, writing, traveling, education through EBFA Global. I am the founder of Nabosa Technology. But really, I'd say all of this is a culmination of my curiosity and passion for human movement, human psychology, the complexity of the human body, mind, and spirit, and really some of it's from my own journey and exploration of myself to understand myself. And then it really travels into how I can better help my patients by understanding emotion, mind, body, relationships to pain, movement dysfunction, etc. So as I had said, I really do hope that a lot of this information is helpful and applicable to your practice. So we're going to kick it off with, this is Julie on the left and this is Sarah on the right. Both of them are 18-year-old dancers. They train in ballet and both of them are experiencing some heel pain, a little bit of plantar fasciitis. Now, the treatment protocol, and if you were to look at the condition of their feet, they have the exact same biomechanical structure of their feet. They have seemingly very similar presentation of their plantar fasciitis. It actually happens to be on the exact same foot. Right foot plantar fasciitis, they've had it for, let's say, ongoing 2 months, but the treatments that you do for Sarah on the right, she responds to very, very quickly, and her pain in her heel resolves with no problems. And then you have Julie on the left, and her heel pain persists, and it persists a little bit longer than you would expect. You then start to order additional imaging to see if there's something that you missed. All of that imaging is coming back as normal, negative for any degeneration, negative for any advanced pathology. Even if you order an EMG and an NCV and different nerve tests, you're still seeing that there's nothing really structurally that is causing her pain. So if you have, let's say, two patients who have very similar presentation, very similar mechanics, similar foot types, similar stresses that they're putting on their body from, let's say, dance, why is it that one patient is responding the way that you would expect, and then the other one is not responding? Well, we know that the body is much more complex than just literally what you're seeing with your eyes. And if you look at these girls, you can actually see that their affect is different. So for Julie on the left has a little bit of a depressed or a subdued affect. Could that perhaps be playing a role in her reaction or her relationship with her pain? Could some of that actually be contributing to the pain? This is clearly what we want to start looking at and understanding when we have our patients. Is we can't be looking at our patients just as physical bodies with physical tissue that you can touch and physical joints that are moving and actual structures that are MRI'd and X-rayed, and that's what you're basing your practice off of. Because what happens when you have the patient that has grade 4 arthritis in their knee, but they're still running and they have no pain, and then you have another patient who has grade 2 arthritis, which should be able to be really fully functional, and they're completely incapacitated? Why is there this difference? So we know that the human body, the human mind is very complex, and everybody has a different experience or a different lens through which how they are looking at their experiences, their body, their injury, their pain. So we need to factor that in and see how that could be playing a role in perhaps their presentation, their potential outcomes, their future injury risk, their future disease risk, and then build that into how we actually shape our practice and kind of shape our philosophy on how we look at our patients. So it really is time for us to look beyond just the physical, literal aspect of the human body, particularly from a musculoskeletal perspective, because when you think of orthopedic, physical therapy, chiropractic, podiatry, etc., a lot of that is the muscle and the tendon and the joint and the cartilage and the fascia. And there's a huge physical aspect to it that we need to challenge ourselves to understand this a little bit deeper. What else could be contributing to those patients or clients' presentation? So this is where we're really looking at the biopsychosocial model. If you are new to this model, this will be a great introduction to start opening up the wide window of how you can be looking at these potential influences on your patient's or client's presentation. We obviously have the biological, that's our genes, nutrition, that would be, literally being able to say the grade health of cartilage, or you could grade ankle sprains based off of that, right? So it's going to be kind of the biological or the physical side to it. And then we have our social. So that's going to be kind of the environmental. Are we really stressed out from work? Are we stressed out at home? And then that's going to really tie in, they're almost synergistic, the psychological with the social, but the psychological is a lot of times the interpretation of the social experience. So if you have, a stressful day, what is your emotional response to that stressful day? And then how does that ultimately influence the biological side, which is, let's say, the genetic side? This is where I'm going to mention a little bit, but where you could start saying, okay, the literal genes is the biology side of the human body, but then there's this term that's called epigenetics, and the epigenetic is our environmental influences that trigger and turn on and off genes. That could be from stress, and it's one of the biggest ones is stress. It could be from things that we're taking in from the environment, whether that's toxins. It could be decisions that we're making, hormone levels that we have in our body. All of that is influencing the then biological through, in this example, the epigenetic influence. We'll go into this much more. Now, this is as opposed to the biomedical approach. So traditional Western medicine, thinking how I was taught in podiatry school, the way that orthopedists are taught, really traditional Western medicine, is built around this biomedical approach. And from a physical therapy, physical medicine, musculoskeletal, we like to look at things from the biomedical, as I had alluded to earlier. If someone has heel pain, right, we're going to go straight to the plantar fascia. We're going to think, okay, maybe they have adhesions in the plantar fascia or the intrinsic muscles that are going into the plantar fascia. So we need to release the feet, we need to release the calves, we need to get that superficial back line mobile, we need to increase the hydration to the fascial tissue. All of that is still staying within this biomedical approach. Okay, so we want to, particularly as musculoskeletal workers, see how we can expand beyond just the biomedical approach. The opposite of the biomedical would be the biopsychosocial. You can also refer to these as a reductionism approach, which is the Western medicine biomedical approach, and that is as opposed to the biopsychosocial or the holism approach. Now we can look at these, and this is a little cartoon to kind of represent what reductionism is about. Reductionism is breaking things down into the parts. So you're reducing it into the parts, and then so you have, the tendon going into the bone, and then you have the ligament, and then you have the retinaculum, and then you have the, tibial artery that goes, and right, so you're like part, and then just assuming that you can conclude why based off on all of the parts. That's really what reductionism is about. So this cartoon is essentially saying, like, here's the trees, and then they're like, wait a minute, where's the forest again, right? So this is as opposed to holism, which is, that's really where you're getting holistic medicine, right? So holistic medicine is typically associated with a more integrative approach to the human body. A lot of it is based off of intuition. So you're kind of feeling the energy of maybe the patient or the way that they're presenting. You could link it a little bit more to an emotional side of things. Some of the other ones is connected, speak about that, synergistic, that as well, holism, right? So there's a lot of these things within holism that cannot be always picked up on, let's say, an MRI or a CT, versus when we look at the reductionism side, again, Western medicine, biomedical approach is the parts, very, very structured, has to be rational. Where's the evidence base? Prove it. There is a very separated aspect to this. It is very mechanical based, objective, looking at the parts, analytical, right? So you could start to see some of this difference between biomedical on the left, biopsychosocial on the right. Now, how do we typically go into, let's say, a patient setting? If you now consider yourself much more of a holistic practitioner, regardless if you're in fitness or you're in any other movement, you're in allied health, you're a body worker might be a little bit of an exception, medical doctor, etc., is thinking perhaps how you had learned this. So if you put yourself back into school, could you say, yes, I could actually see the way that Western medical school is very, very reductionism, and we need to see it on the MRI to diagnose that for the patient. Versus perhaps now you do already see your patients and clients more holistically, right? You think about breathing, you think about their diet, if they're stressed out, their autonomic nervous system, cortisol levels, right? You're already starting to get into this holistic approach, which is amazing. And if you are already in that direction, I congratulate you, because that's really what we need more and more health and movement specialists in that holistic biopsychosocial approach. So we're going to be taking a closer look at this holism approach. Now, where you could start to see some of these differences as well is related to pain, and we're going to be speaking about pain. So the biomedical approach for acute pain is amazing. This is really where you do want to use the reductionism approach, the biomedical approach. If someone comes in with, an acute ankle sprain, I do want to order the MRI. It is justified, but looking to see if they tore a ligament. You come in after a skiing accident. Yes, I want to see if you tore your ACL. That is 100% appropriate treatment. Now, if you're looking more at chronic pain, that's completely different. That's where we want to start looking at the biopsychosocial, the holism, the outside of the box intuitive way of looking at why can they not get past this pain? Why do they keep having this movement dysfunction that has a deep-seated or deep-rooted emotional tie to it, right? So you could see where we want to start putting our attention. So when we look at chronic pain, the chronic pain patient or client is one that you want to go at them with a deep understanding and I would say respect for what they're going through, knowing that chronic pain really can be demoralizing, and the individual that is in chronic pain really feels this daily ongoing stress and difficulty that it just infiltrates into every aspect of their life, and then it starts to affect their family and their family's life, right? Because it's putting them in this state of helplessness and hopelessness. Many of them are depressed, and for the chronic pain patients that I've seen, they're continuously on this hunt for the magic treatment that's going to poof take away their pain. And unfortunately, it's not that easy. Now, another side to understanding chronic pain is when a client or a patient presents with medically unexplained pain. So the medically unexplained pain is something that we want to appreciate as well. And this is often referred to as a somatic syndrome. Maybe some people will put it that it's, in their head, quote unquote, which is not a way that you want to be addressing this, of course. But it is related to a pattern of persistent pain that does not match the way that the patient or client is actually presenting. So if you were to do a physical exam and palpate different areas of the patient's knee or ankle or shoulder, wherever their complaint is, they are having this pain out of proportion, something where you're like not even touching them and they're like, oh, right? That's starting to kind of tip you off to, okay, this is not matching the way that they're actually presenting. What you want to refer to this as is as a body distress syndrome or a body distress diagnosis versus saying it's something in their head, right? So we just want to call it body distress. And a lot of these patients, unfortunately, or clients, unfortunately, will go from doctor to doctor to trainer to trainer to therapist, and either it's a little bit of the therapist or the doctor kind of getting a little bit frustrated, so they spend less and less time with them just because, what else can I offer this patient or this client when what I've done is not working. They're getting frustrated. I'm getting frustrated. And then they kind of drop off, and then they find someone else, and they continuously do this in a cycle, right? So they end up feeling like a medical orphan. Some examples of these medically unexplained pain can be IBS, fibromyalgia, chronic fatigue syndrome. A big one is non-cardiac chest pain. That is a huge one. Chronic headaches. What I see in my office is a lot of idiopathic neuropathies and neuralgias in the foot that just are not matching. And even if they get EMGs and NCVs, they're coming back as normal. Back pain, diffuse foot pain, I've seen it as well. So depending on your specialty, there are going to be some of these specific ones that you might be seeing. Now, the biggest thing that I try to appreciate, especially the more that I study biopsychosocial, is that each of those patients, when they come in, even though I'm palpating and they're not responding in any way that you would typically respond, I still try to respect what that patient is going through, because it is something very complex and they don't really want to be in that situation. Like deep down, they don't want to be in that situation. There's some other driver to why they're presenting the way that they are. And each of those experiences that they're going through is very personal and very private. So the patient or the client, just as much as we, the professional or practitioner, need to honor their experiences and respect that what they're going through right now is in place for a reason, because it had to do with survival, right? So if they are, let's say, very depressed and have this dissociative disorder with their body, and let's say some presentation like that, and then it goes into IBS or fibromyalgia or something like that, that still was there for a role to help them to perhaps suppress some trauma that they were going through as a child. So you still have to honor that role that their body went through to protect them. And understanding that there are powerful influences on pain, and how those emotional influences affect pain. By first understanding them, then you can bring them to the forefront to the patient or to the client. And I feel like sometimes in a doctor's office, maybe you only have so much time. Maybe you don't want to open Pandora's box into something. Maybe you don't want to be slightly nosy, or like poking into someone's personal business when it comes to emotion. But asking patients or clients, particularly those in chronic pain, like digging a little bit deeper about their emotional state. Like, how are things at home? How's your relationship with your husband? Kind of digging a little bit, because their state, their anxious state, their depressed state is really further enhancing that chronic pain that they're experiencing, or the medically unexplained pain that they're experiencing. And then that, of course, translates into movement dysfunction. So if they're very anxious, of course, that's going to increase their pain perception. Patients that are anxious have a higher pain sensitivity than those that are not anxious. So understanding that's really important. A lot of that links to breathing patterns. And if a patient is under an anxious state, that's going to change their breathing pattern to be supra-diaphragmatic. And then when you breathe supra-diaphragmatic, you change the baroreceptors in the lungs, and that in itself is changing their pain perception. So more anxious, more sensitive to pain, because of the supra-diaphragmatic breathing pattern and the baroreceptors, right? So how can we use that for our clients and patients? Boom, get them into some sort of diaphragmatic breathing, get them sub-diaphragmatic, just so that they can get a little bit more of that connection with their breath. And what does that do to their perception of pain? What does that do to their overall sense of well-being? Huge, right? And then the same thing for depression is getting them to reconnect to their body. A lot of people who are depressed have a disassociation from their own body. Perhaps there's some shame element to it, that they don't want to really feel their body, connect, be one with their body, and so they therefore disassociate. So why does one patient respond with anxiety and another respond with depression? This has to do with how we created our imprint or our outlook in the world, right? So that would really be referring to our psychosocial perspectives, and everybody has a different psychosocial perspective or lens through which they look at the world and they base their experiences off of, right? That's their reality. And that interpretation of the reality is imprinted way before we even have conscious thought, which means that the impact of psychosocial influences is beyond something that most people, most of our patients and clients are even aware of. If you've heard of Eckhart Tolle and you've read his book, The Power of Now, he calls it being conscious. So we are trying to bring a consciousness to society, and that consciousness to society really is getting people out of their subconscious psychosocial influences and having them become more aware. So these are imprinted in utero, and understanding in utero development is really important to understanding how each and every one of us as an individual starts to shape our relationship with the world and with others and with ourselves. So that's going to be referred to as either in utero or perinatal influences that start to affect the fetus, the child, the being, for the rest of their life. So one of the most impactful perinatal influences that happens to all of us, or that's the most concerning for any of us to go through, is stress, maternal stress. If there is any stress, maternal stress, during the period of conception to birth, that can forever imprint the child, the being. And I'm going to go into exactly how we start to see this. So when we're looking at stress, just as a reminder, so everyone's on the same page, we are referring to the HPA axis, which is the stress pathway triggering cortisol. So cortisol is a hormone, and this hormone, we will see, can start to influence many aspects of the body, many aspects of the developing fetus, and it actually imprints into the memory of our cells, and that will forever be imprinted. So the actions of the cortisol are usually tightly regulated. However, any sort of stressful event can keep it chronically elevated, and then that's when it starts to become dangerous. So we want to watch the uncontrolled stress, because controlled stress and occasional stress is actually healthy and normal and necessary to remind our nervous system that it has a role there, right? Our nervous system is there to protect us, and having that balance of control and down regulation of the stress response is very powerful. So it's the stress without sufficient down regulation of the autonomic nervous system, that is what's going to be damaging. Now, if you are familiar with the term vagal tone, vagus nerve, autonomic nervous system, right? That's a lot of what we're speaking about here. And what a lot of people start to think about with the autonomic nervous system and the vagus nerve has to do with sympathetic and parasympathetic. So that's oftentimes what we go after. We go after the sympathetic being our fight or flight, and then the parasympathetic is our rest and digest. However, according to Stephen Porges, I highly recommend you looking at his work. He has some incredible videos that are on YouTube, many free lectures on YouTube with Stephen Porges. Please do check out polyvagal theory. So what he speaks about is that there's actually two vagus nerves. There is a myelinated and an unmyelinated vagus nerve. He'll often refer to the myelinated vagus nerve as the smart vagus. That's like the newer evolved vagus nerve. And that's one that has to do with socialization. So facial expressions, vocalization, hearing. It actually helps to regulate the inner ear and the way that vibrations go through, which is very, very interesting. Now, this is as opposed to the reptilian vagus, which is obviously older. Think of it like the brainstem. Brainstem is the reptilian part of the brain. So the reptilian vagus, almost like a reptile, when it kicks in with this fight or flight response or a stress response, it creates an immobilization response. This immobilization response is a survival strategy of the reptile, right? So it's thinking the turtle putting the head back into the shell, and that's the way that they avoid threat or stress. Versus mammalian, now we're dealing with much more of runaway, right? So it's a different type of response through the autonomic nervous system. Now, depending on where you are in the stress level, right? Some people will choose the fight or flight, run away from the threat, or let me stay here and fight threat. However, if you stay in that stressed situation too long, then the old vagus nerve or the reptilian vagus nerve supersedes it and overrides it, and then it immobilizes you or plays dead. Yeah. So a good example to this would be you are in the wild being chased, I don't know, and a tiger's coming after you and you're running away from the tiger, and that would be your mammalian response, right? And then you're realizing that you're going to get caught, right? So you are now overriding because you have to go to the next level of, okay, instead of me getting caught, which eventually I might, let me just play dead, right? That's going to be you going into the reptilian response. Now, another example of this, real quick, is I was listening to this, I think it was in one of Stephen Porges' lectures, and it was a really interesting thing that kind of hit home, is he said that he was watching the news, and there was a plane that was making like an emergency crash landing type thing, not crash, but emergency landing, and it was really, really, really unstable, and people thought they were going to crash, and super traumatic. So there was the news station there, and they were interviewing some of the people, and they went to this one woman and were like, how did you feel? Like, what were you feeling in the middle of this, plane crashing? And then were you like just elated when you landed safely? And she was like, I passed out. I actually don't remember anything. I completely blacked out this whole situation. That's an example of her autonomic nervous system went into, okay, this is I might die, and the I might die is kind of the top level threat, and it goes into this immobilization vagus. Very interesting. So individuals who go through lots and lots of trauma early in life start to tap into this immobilization vagus, and they start to experience this disassociation and depressed state because of the stimulation of that aspect of their vagus nerve. Now, to go on a little bit more, these are a few different research studies showing the mother-fetus influences related to stress. So first study looked at fetuses of anxious mothers had greater increases in heart rate in utero, and that heart rate pattern matched the mother. So when mom gets stressed, baby gets stressed. And any of the damaging effects that we understand as health and movement specialists of stress, that's going on to this very naive nervous system in utero. Second one, Farber saw an increased risk of prematurity in anxious mothers. Now, you know that premature babies in itself are at risk for many health conditions. So another question that you could start asking your clients or patients is, were they premature? That will tell you a lot about their resiliency, almost you could say, or the state of their health and their trauma state, early trauma. So anxious mothers also, in addition to the prematurity, the children had altered mental and motor scales. That was interesting. Last one saw that maternal anxiety symptoms was an indicator of stress during fetal life. Okay, we know that, and may increase the risk of development of asthma. That's interesting as well, right? So any of the clients that have asthma or the patients with asthma is looking at the role of maternal stress in the development of that asthma. Now, to look a little bit more to understand this, again, really shaping how are we painting our picture, has to do with the understanding of when pain is first introduced. So pain is first introduced in utero when we are just 16 weeks in utero. We are able to feel pain. Now, the conscious mind has not developed yet, but we are still feeling the pain. The fetus is still feeling the pain starting at 16 weeks. So that's going to be built into what is referred to as a implicit stress. So a unconscious stress that will imprint that child, that will imprint the patient, the clients of pain that was experienced in utero. So if you have a client that was born from, let's say, not a safe setting, maybe there was an abusive boyfriend to the woman who was pregnant, and there were any situations that fetus would remember that pain. Now, fetuses will respond to painful stimulation starting at the approximately the fourth to fifth month, loud noises, and as I had mentioned already, the maternal stress hormone. Now, this is not consciously remembered, but this is implicitly remembered. Hearing and learning begins 5 months in utero. So that is a huge, huge application as well. So fetal development and memory. So pain and pain responses has to tie in with memory, thinking, what do we remember from our earliest experiences? And then how does that affect us? Because our memory shapes our interpretation of the world and our imprint. So our memories are unwittingly influencing us, from explicit to implicit, from conscious to unconscious. We carry memories in the cells of our immune system. We carry memory in the cerebral cortex, and we carry memory in the cycles of family patterns. This book is absolutely incredible. Pre-parenting, nurturing your child from conception. Even if you are not planning to have a child, I would read that book. Reading that book helps you to understand how we are first shaped, how our nervous system develops, how stress influences and shapes the immune system. So very powerful book that I encourage you to read. Now, to go a little bit more off of this, understanding implicit versus explicit memory, because it's memory of the experiences that are shaping us. Implicit memory is acquired and unconscious. So we develop it unconsciously, and then we're using it unconsciously. Now, 95% of your memory and your behaviors and your actions day to day are implicitly influenced. They are unconscious or subconscious. So that is a huge response. Now, that is linked to the amygdala. So for those who are familiar with the education that we do through EBFA, the amygdala is almost like your knee-jerk reaction part of the limbic system, which is, again, linking to you being subconscious. If you are creating emotions subconsciously and you're just subconsciously reacting to the day-to-day and you're not even aware of what you're doing, then that makes sense, right? So the opposite to this is your explicit memory, which is acquired and used consciously. This is going to be 5%, more 5% of your day is going to be explicit memory. This is linked to the hippocampus, and the hippocampus is your memory center part of your limbic system. This is also part, if you've taken any of EBFA's education before, I speak about the hippocampus being at risk to stress. So the HPA axis stimulation that releases cortisol is damaging to the hippocampus. Cortisol in itself is damaging to the hippocampus, which means that people that are chronically stressed start to have compromised memory recall and memory retention. You can also sometimes see that there's a decrease in hippocampal function in different chronic neurological conditions such as Parkinson's, MS, etc. So just had to do that little shout out for Carl, the Parkinson's. So understanding how if someone has a deficit in their hippocampus, which is going to be explicit memory, because they're stressed out, they now become even more functioning on implicit memory, which is this more subconscious, unconscious way. I hope that makes sense. So if you have perhaps experienced some sort of stress or anxiety or trauma growing up, intra-utero, through birth, early childhood, and that imprints your implicit memory bank, then if you are very stressed out, your explicit memory bank goes down and you have no choice but to become much more implicitly influenced. Yes, so that's going to have a huge effect on our patients and clients as well. Now, last type of memory that I want to focus on, which is also extremely interesting, is cellular memory. So now before implicit, before explicit, there was cellular memory. And cellular memory is literally every single cell from egg and sperm first connecting, zygote dividing into the blastocyst and going all the way through our embryology of how the cells divide. Any stress during that period, during that division, will forever be remembered by the cells. And that cellular memory, a great example of cellular memory, has to do with the immune system. Now, if you think of immune cells, and if you were to inject with a vaccine, so a vaccine is particles of a virus, and then the particles of the virus create a small immune response by the body to essentially create a memory of that response, just in case if the actual virus comes in, let's say the flu, right? So you get the flu shot, and you get a little bit of the virus, and then some people will actually create a little bit of response. It might feel kind of flu-ish, but then if you actually get hit by the actual virus that happens to create the flu for you in that strain of it, you would then trigger that remembered immune response. Yeah, so that's one of the first examples of memory in the human body. That is a form of memory because your cell remembers the virus. Think of that with all of your cells have a memory. So those cellular responses before the brain is even shaped. So before 16 weeks, if there's still stress and anxiety or stress within that in utero response, you will remember it. Your cells, your body, your being will remember it. So in chronic neurological conditions such as MS, stroke, Parkinson's, Alzheimer's, a lot of these are actually linked to physical, chemical, and environmental stressors that are affecting the neurological system and the immune system. So stress is a huge contributor to these conditions. And that category is neuropsychoimmunology. Neuropsychoimmunology. Another example of how you can think of this is for people who have good moods, versus bad moods, right? So the day-to-day relationship with the world can affect your immune system, and that's why some people are chronically sick and other people just are really resilient and never get sick, never get colds and flus and things like that. Now, why that's happening is because the viruses and the neurohormones, the feel-good, happy neurohormones, share the same receptors on our immune cells for cell entry. So if there's X number of receptors on a cell and you are in a positive affect, you are happy, you have dopamine levels, all of those neurohormones are filling up all of the receptors, that there's no empty receptors that the virus can take, which means the virus cannot get in the cell and you don't get sick, which is pretty cool. So that would be neuroimmunology. To take this a little bit further, there is what's called critical periods of development. This is both in utero and out of utero. Now, the critical periods of development are happening during fetal life and again postnatal, right? And this is when the tissues and organs are going through a very specific period of programming. Now, if you happen to not have a certain stimulus at the right moment, then you might not trigger that critical period of development. And that could, of course, forever have a lasting effect on your immune system, your development, your injury risk, your disease risk, etc. So ensuring that we have an optimal nutrition, we don't have neurohormones that are out of sync. Everything that is happening from an environmental perspective in utero needs to allow these critical periods of development. Now, a quick example for this, which is not entirely linked to movement dysfunction and chronic pain. However, it does have an emotional state, and I don't actually know, maybe some of you want to type in if you are familiar with any statistics related to this, but gender identity and associated maybe autoimmune conditions or chronic pain or medically unexplained pain, etc., kind of like along that relationship. Let me know if you happen to, because what I'm going to go through now is going to speak about this a little bit. So related to gender identity and this critical period of development, this is happening in utero. So maternal stress is actually a huge influencer on gender identity development in utero. Now, your actual sex organs form at a different period than the gender identity in the brain, okay? So if you're developing, based off of X or Y chromosome, the sex organs for male versus female, obviously that's kind of setting what you are. However, the later period of development is the gender identity. That has to happen at a very specific period. And that's an example of a critical period of development. Now, hormone levels are a huge influencer of this. In utero, estrogen is considered masculine. And then in utero, DHT, which is the other derivative of testosterone, is going to be feminine in the womb. Now, in the womb. So if you happen to have perhaps your testosterone trigger is at the wrong time, it's a little bit too early, or you have very high elevated levels of estrogen, you could see where this is going to start to change the brain gender identity side of gender identity. So all fetuses start as female and then they differentiate as such. So we want to make sure, from another reason of kind of the optimal gender identity that's matching sex organs, a lot of that has to do with maternal stress, which is very interesting. And then how does that then translate into what that individual is feeling, which is a whole nother topic of chronic pain, movement dysfunction, immune function in those that are going through this gender identity. So now critical periods of development postnatal. So this I'm going to read. You don't have to read it. I'll read it. This is an example of a critical period of development postnatal, so after birth. Now this says the development of the sweat glands provides an interesting example of the critical period of development. In the early years of this century, Japanese military expansion took their soldiers and settlers into unfamiliar climates. They found that there were wide differences in people's abilities to adapt to hot climates. Physiological studies showed that this was related to the number of functioning sweat glands. People with more functioning sweat glands cool down faster. Now, rather than attributing these differences in sweat glands to genetics, which a lot of people like to do, Japanese physiologists explored a little bit more into the early development of sweat glands. They found that at birth, all humans, babe, can you not throw that? So they found that at birth, all humans have similar number of sweat glands, but none of them function. In the first 3 years after birth, a proportion of the glands became functioning depending on the temperatures to which the child is exposed. The hotter the conditions, the greater the number of sweat glands that are programmed to function. After 3 years of programming, this is complete. The number of sweat glands is fixed. The development of the sweat glands encapsulates the essence of critical periods of development. This critical period of development is a period of being plastic and sensitive to the environment. This is followed by a loss of plasticity and a fixed functional capacity. Mic drop. So that is a huge example of this critical period of development, both in utero and postnatal, and seeing how that could start to influence our relationship, our stress levels, our immune systems, our illness risk, etc. So now we take this a little bit further. I know that we're going for a while, so we're wrapping up soon. So homeostasis theory and attachment. So this goes a little bit further in that postnatal aspect. So our attachment with our caretaker. Usually it's going to be linked to the mother, but it's not always. So the caretaker, the affect regulation is related to this attachment style, and it has to do with our capacity to be soothed and to feel secure. That is set in the first 3 years of life. Now, the attachment of the child is critical. Everything, when you follow Bruce Lipton's work, he says everything is to age 7. So age 7 is where you really are shaping the imprint. Some of the others say age 3. Still great to kind of keep that window. Pushing it past 3, you'll have a more resilient child if there happens to be some sort of stress, etc. But during that period of that attachment setting, the child everything is about the child, and children are very narcissistic, and the world is really related to them, which means that if you are not paying attention to the child, they take it personally, right? And then that starts to create a lot of these imprints of how we view the world. Beliefs, if you want to call it that, subconscious beliefs. So from the attachment style, this is a very good book if you want to learn more about attachment styles. So secure, anxious, ambivalent, avoidant, being a little bit detached, being insecure. So an insecure attachment style has an associated lower vagal tone, a higher perceived stress level. So what is that doing to the cortisol levels? Huge. Imagine if you had insecure attachment style mothers, what that's doing to their child. And then this starts to become very generational. Now, attachment styles are if you want to associate it to the avoidant or the detached. So body avoidance is often linked to emotional avoidance starting in early childhood, so the detached. All clients with body distress syndrome, which we mentioned earlier, so the medically unexplained pain, should be questioned about emotional closeness to their parents. What was that relationship like? Those who experienced early trauma are often oblivious of their body sensations. So maybe those would be ones that can't really explain what they're going through. They can't really describe their pain. So obviously some somatic work would be huge for those patients and for those clients. So as we begin to wrap up and start to summarize this, if you guys have any questions, please type those in. We are now getting towards the end where we want to start thinking about how can we integrate this into our practice, whether it's from a fitness perspective, it's a body worker, it's medical, physical therapy, is thinking of again, everyone's influence is different, and everyone's influence or relationship to the world is starts from in utero, right? So the questions that you really want to be asking them really would be related to kind of that early childhood. I mean, really, it would even be going so far as to ask about the birth history that most people probably don't know, but finding as much as you can would be very powerful. Now, some of the tip-offs that you might want to explore a little bit more in the biopsychosocial influences with your clients has to do with any client or patient that exhibits perfectionism or a type A attribute. Those are typically, right, they're trying to make up for some sort of belief that they have. Does the child suppress or stuff their negative emotions down? They don't want to talk about it, they don't express it, everything is happy-go-lucky and nothing's ever, vulnerable. That would be a trigger. Did the client experience verbal, physical, or sexual abuse as a child? Obviously, that's going to be massively impactful. Does the client or patient experience interrupted non-restorative sleep? That's going to start to chronically affect the autonomic nervous system and their stress response. Is the child experiencing marital or interpersonal problems? So, right now they're going through a stressful period. Does the child client present with facial tension, elevated shoulders, or body guarding? Definitely want to look for that as well. Does the client or patient report teeth clenching or grinding? Or does the client or patient exhibit dysfunctional breathing? So those would be just a few of the kind of tip-off, I guess you could say, tip-off triggers. And now kind of how can you start using it? Now, this is how I use it in my practice as a podiatrist when I'm seeing patients with chronic pain, chronic movement dysfunction, etc. I happen to see a lot of patients with chronic nerve pain, and it could be a neuralgia in the foot, it could be diffuse in the bottom of the foot, the top of the foot, idiopathic neuropathies, severe pain. They can't find any issues that aren't killing them. The skin on the bottom is super sensitive. Just to like lightly touch the foot, the bottom of the foot is ow, ow, ow. I see a lot of that. And when I first started seeing patients like that, when like in residency and early practice, I'd be initially like, oh no, because I didn't know any difference. I was like, oh my gosh, what is going on? Especially when I was a student, I was freaking out that they could have lots of stuff wrong with them. And then it would just really confuse me when I was in my earlier practice, because I was looking and looking and looking for the physical. And when it wasn't the physical, I was like, well, I don't know. Then I started doubting my, diagnostic skills and capabilities when I was very early in my practice or residency. And then I started to see a lot of that in where I did my residency was in a lower socioeconomic hospital neighborhood. And I would see it a lot. And I was just like, are these patients just trying to get attention or what? Because it would just confuse me that I'm like, there's no way that is painful. And then I would just think that they were kind of like crazy or something, versus actually kind of pulling away and being like, okay, let me see, this is actually a window in to help these patients in a different way. they come to me, happen to have foot pain, but could I guide them in a direction that could really go after what they're looking for? Like they do want help, but in a completely different way, right? So now in my practice, I build it around, you can see these steps here, I'm building somatic awareness. So all of my patients, I'm guiding them into the power of meditation, the power of yoga, or a body weight movement practice that requires breathing and intuitive inflection, right? Or inward reflection. So that would be really reconnecting to the breath, building the somatic awareness. And then you can even go so far as this emotional expression through movement. If a lot of them are not used to moving, there's just a powerful response to moving in itself. Even it doesn't matter what kind of movement it is. So having that, what I would say would be one of the biggest recommendations is that you don't have to become a therapist or a psychologist. You don't have to try to, like, I'm going to be the one that fixed their childhood trauma. Like that's not what the point of this webinar is. It's more appreciating and, you know, perhaps respecting and hearing what they're going through, and then offering them something that maybe someone else has not offered, which I recommend. There's a book that's called When the Body Says No by Dr. Gabor Mate. I had mentioned that at the summit as well. I'll go back to that quote in one second. But I actually give book recommendations to my patients, and I will explain to them when I'm looking at their stack of MRIs and nerve studies and x-rays, and I do my evaluation, and they've seen probably 20, 30 other doctors in their lifetime for different, maybe the same issue. And recently I've started doing this just because of really just knowing the power of this, is telling them that there's a lot of pain that can't be picked up on a Western medicine test. So you don't need to order another MRI. I'm not going to do another ultrasound or nerve test because all the previous 10 ones have been negative, and that we need to understand or respect that there's certain things that just will never show up on that. So if there is, and I try to explain to them that there's teeny tiny, you know, nerves that go into the skin, and teeny tiny nerves that go into blood vessels, and that those will never be picked up on these big Western medicine tests. So I need them to understand that what I know their cause of their pain is more this intuitive gut feeling of what's causing their pain. Yeah, which is kind of the holistic approach. And then speaking to them and starting to open the conversation related to emotional state and the anxious state, and explaining that when we get anxious, because we're in chronic pain, so I understand that it changes our breathing pattern. And when we change our breathing pattern, that changes every aspect of the body. If we get stressed out about something, what that does to our sensitivity to pain, it actually goes up. So I try to educate them on this, and then I give them a recommended list of books. A lot of them are Dr. Gabor Mate's books, but I will also guide them into you know, Biology Belief, Bruce Lipton stuff, just kind of starting to open the conversation slowly, because you have to build trust. And then as they start to see some of this response and doing the breath work and the somatic work, they may start to change their relationship to their pain. And them understanding that they're not identified by their pain is also very powerful. That, you know, you have chronic nerve pain in your feet, but you are not defined by that. That is a sensation that, yes, you may feel every day, but you are still the artist, the teacher, the whatever, the mom, the, you know, the sister, just so that they understand that they get so wrapped in the pain. So these are some of my favorite resources. Dr. Gabor Mate, listen to his stuff on YouTube. Again, he has many lectures, just like Dr. Stephen Porges. The bottom one has many lectures available on YouTube. Check it out. Dr. Thomas Averney, The Secret Life of the Unborn Child. Another one similar to that is Windows to the Womb, which is by David Chamberlain. I would check out that one as well. Dr. Chris Walling does somatic psychotherapy. There's actually this journal on the bottom, which I was super excited to see. This is a whole medical journal with research on nothing but biopsychosocial in medicine, biopsychosocial theory in medicine. How powerful is that? Most of the research studies, very interestingly, are done in Japan. So their outlook on things is very different. So if you guys have any questions, you may type those in. I hope that you guys had fun listening to this. To me, it's a fascinating topic. I could keep talking about it for another hour, but I won't. So you can type in your questions if you would like. And I'm going to end with this quote, this Aristotle quote. My apologies for the alarms or the sirens. Soul and body, I suggest, react sympathetically upon each other. A change in the state of the soul produces a change in the shape of the body. And conversely, a change in the shape of the body produces a change in the state of the soul. I love that quote. All right, so I'm going to go back to the resources so you may see those. And then if you guys have any questions, I will answer those. Let's see. Thank you to everyone who's saying thank you or you're welcome. Can implicit memory affect explicit memory in performing physically complex stuff and or coordination? Yes. So the way that's a very good question, Jay. So can implicit memory affect explicit memory? Let's say if you're performing a complex task or coordination. Yes. So the example would be, let's say if you were learning a new skill and you self-doubt yourself. So one of your implicit beliefs, subconscious beliefs, is that you're not good enough, or you are always messing things up, and you're just clumsy, and that's just how it is, right? So when you're learning a new skill and a new coordination, you're going to go into it with self-doubt and almost like defeated even before you gave yourself a chance to learn it. That would be the application that I would see. Since cellular and implicit memory develop as a fetus, is there technically no way to change a person's outlook? So now the way that you would change the outlook, sorry, I didn't mention that, is through, you know what I will do? I will send everyone this incredible lecture by Bruce Lipton, who's the author of The Biology of Belief. And it's a 20-minute kind of TV interview that he had done that was really good. And he said that there's 3 ways that you can change implicit memories and subconscious beliefs. First one is through hypnosis. And when we're a child and we're just first taking in the world, you're essentially in that hypnotic state. The other way that you could use hypnosis could be through listening to things when you're falling asleep. So like a self-help or a meditation as you go to sleep, and it's saying positive things. So it's when you're getting into certain brain waves that's going to actually change your implicit beliefs, would be through, that's also hypnosis. Second way is through repetition. So repetition would be continuously keeping the positive habit or the positive self-talk or the positive motivation rituals that you do to change your beliefs, right? And to achieve success or self-love or whatever it might be. That would be the repetition. So day, you're doing this. And then the final one is through, I think he called it energetic healing. It's like NLP, if you've ever heard of NLP. And then the other program is called Psych K. Both of those have to do with resetting the subconscious beliefs. Those are done with a practitioner. Again, I will send you the recording so you can learn more about it, but definitely saying those three. For me, myself, and my own experiences, I've done all three of them. The hypnosis kind of at night, listening in the headphones, definitely done that. The repetition of listening to positive, motivational kind of mindset stuff, I've done that every single morning for the past 3-4 years. I'll listen to 30 minutes of Tony Robbins and stuff like that. And then third is I've done NLP, which is changing the actual subconscious beliefs. You have to believe it for it to work. If you are very skeptical, then different things like this are not going to work, but technically that would be your implicit memory that's preventing you from changing it, right? So let's see this. Pilates instructor, anxious. You have a client that's anxious and easily stressed out. Okay, she knows this. She lets on that she has been to psychiatrists to help in the past to help regulate her anxiety. She comes to me with lots of phantom pain. Okay. And I say phantom because she described that as such. Come and go on a daily basis, and the pain runs around her body. She's extremely sensitive to pain. Okay, body distress syndrome. She has identical twin sister. Interesting. So this client that this woman is describing, who has body distress syndrome, kind of very anxious, has an identical twin that is completely fine, no pain, but what she gathered is that they have completely different personalities. So the twin, one twin is cheerful, upbeat, happy, and then the other twin, which is her client, is anxious and has a different affect. So that is so interesting. If you read the book, the Pre-Parenting, the Thomas Verney one, he actually speaks about that. And then so does the David Chamberlain, that there's something that is that you can have twins and then one is like a ghost, where the other one you will have just the yolk sac and the fetus doesn't actually develop. That's another still sort of kind of impact on a child. Very, very cool. Every time you try to progress with her, more movement. Okay, so she's kind of, how can I progress with this? You know what I would do is I would look at perhaps some of this NLP and the Psych K for her. That's a really good question, Pishan, that what she's presenting with, and the fact that her twin can be completely normal. Twins have completely different experiences in utero, and sometimes one twin can actually have a healthier placenta than the other. Their growth, their weight at birth, definitely the time that they were in, let's say, the birth canal could be different, and then that's going to create a different experience for both of them. That's a really good question. I'm glad that you answered that. Embarrassing themselves. Oh, yeah. Okay. So Jay had another good question. So if a person has pain, quote unquote pain, because they don't want to embarrass themselves, so they use pain as a reason to not to have to perform or make it real in the long run. Yeah. So that's obviously, that's also a belief that they're not good enough, that they're embarrassed, that they won't be accepted by the others if they don't perform it correctly. Right. So again, that goes right into the same thing. Psychosocial influence is for them. So can you help make that individual, or bring a consciousness to that individual, which is the awareness? You guys have such good questions. I'm sorry that this webinar is long, But for those who do have to go, I totally understand. For those who are hanging on still, I am still going through a few of the questions that are really good. Okay, so this is a question on chronic back pain and neck pain. Some told her that she would be in pain indefinitely. And then she became a yoga therapist, pursued every avenue of healing. Now, 12 years later, I'm assuming she has no pain. Yeah, that she's out of pain. So, yeah, I mean, that's a really good example of Natalie saying that doctors told her that, you know, you're going to be in pain. Your outlook is negative or not good. You will always be in pain. You will always do this. So we need to do the neurectomy, or we need to do the epidurals, or we need to do, you know, XYZ. That's really taking the biomedical approach and not saying or respecting how powerful the mind is in not only the side of enhancing the pain or creating like medically unexplained pain, but the opposite, which is what Natalie is saying, is that could the mind actually heal the body? And there's tons of stuff related to that. Look at Bruce Lipton's stuff as well. He speaks about that a lot, of people healing themselves of different issues just from the state of the mind. That has to do with the neuroimmunology side of things, neuropsychoimmunology, right? Positive affect, totally going to change your immune system. Absolutely, 100%. Dr. Gabor Mate speaks a lot on cancer and stress or relationship to the world. So people who feel like they have to serve everyone but themselves. So they're like people pleasers, right? They're doing that for a certain reason, and they take care of everyone but themselves. So they subdue their own needs. And someone who's continuously subduing their own needs, that's a lot of internal stress, and that internal stress leads to cancer. And really, really interesting take that he has on his. So please listen to some of his lectures. And effects on the fetus. So Tracy asked a question about links to the articles regarding stress in the mother and effects on the fetus. Look at the book by Thomas Verney, The Secret Life of the Unborn Child, or his other one, which is the pre-parenting. Both of those talk about that. So you'll be able to get it from that. Okay. Hi, Christine. Is the time of the imprint also? Yes. So a really good question about if you have someone that is cognitively delayed. So so the IQ side of things. If who has the question, is remember the brain is IQ, EQ, MQ. So for those that have a delayed development of the IQ, you often see a delayed development of the EQ, which is the emotional flexibility. The emotional flexibility is also linked to that amygdala, hippocampus, that relationship with the limbic system. So that's going to be affected as well, 100%. So it can change the consciousness to their behaviors. So they are definitely imprinted, but they're probably imprinted more subconsciously than consciously. So a really good question on the lungs, and this will be my last question. Thank you guys so much for staying online. So last question had to do with the lungs, and that lungs causing issue. Can the ability to use our lungs cause issue? If you're not getting full use of the diaphragm, So whether you're breathing in an anxious style, or you're breathing because you have COPD or emphysema, scar tissue from, a history of lung cancer, kind of in different ways that you might want to see it, you're not going to get full use and dance of the diaphragm, if you want to call it, and that full motion and function and utilization of the diaphragm into the lungs creates on one level, creates the link with the pelvic floor that we speak about a lot with EBFA. So optimal breathing goes to diaphragm, diaphragm connects to pelvic floor. Those two areas need to be in unison, integrated, to create central pelvic stability. So dysfunctional breathing patterns, for whatever reason it might be, can start to affect the entire lumbo-pelvic hip complex in the way that it dynamically stabilizes. The other way that you could look at it could be not full utilization of the diaphragm in the lungs starts to change the baroreceptors, right? Change the oxygen CO2 exchange, say that as well, is going to affect the lymphatic system. For anyone who is at the Barefoot Summit, that's part of this whole system as well. So there's a lot of compounding effects that can come from not optimal breathing, which is why I feel like there's this huge shift into breathing within the health and fitness and movement industries. It's that for a reason, because that should always be step one. You have to get the breath down. If you don't have the breath, you're not going to be stable. If you're not stable, obviously you're not going to be able to dynamically control your movement. But also, if you don't have optimal breathing, you're just not getting oxygen to your tissue and the nutrients to your tissue. So I hope that helps. If you guys have any questions that you might think of after we hang up, you may email me at education@ebfafitness.com. If you want the PowerPoint, email me, education@ebfafitness.com. We will have this on the YouTube channel. We will also be sending it out, and I will be sending you a couple videos as well for the Bruce Lipton, some of the Gabor Mate, the Stephen Porges, just so you guys have some additional information that you could read. Thank you guys so much. Thank you for tuning in, and I will see you again on another EBFA webinar. Bye.